Hello, everybody. My name is Elizabeth Lewis, and I'm a Senior Project and Policy Coordinator at the International Federation on Aging. I'm honored you chose to spend your time with us here today, and we will be discussing the project Increasing Cross-Sectoral Collaboration and Advocacy Efforts for Ear and Hearing Care Services. Today, I will be joined by our fantastic expert speakers, Dr. Sue Archbold, Dr. Kathy Pecora-Fuller, and Dr. Joshua Chodosh. So please stay tuned to learn more from them on the relationship between hearing loss and dementia and the importance of cross-sectoral advocacy. First, I want to provide a bit more information about the International Federation on Aging and our perspective. The IFA is an international non-governmental organization with a unique membership base comprising government, non-government organizations, academics, industry, and individuals in over 80 countries. For the last 45 years, the IFA has become known as a leading and innovative organization that works across disciplines and sectors towards common goals that improve the lives of older people. IFA's mission is to drive the agenda of the world's aging population so that every older person can live life to the fullest in a society that respects their past, present, and future contributions. The IFA's goal is to be a global point of connection and network of experts and expertise to influence and shape age-related policy. Population aging is progressing at a rapid pace worldwide and poses challenges for countries' economies, with the health of older populations being of considerable concern. There is currently more than 1 billion people over the age of 60, representing roughly 14% of the global population. By 2050, this population will have more than doubled to 2.1 billion. With increasing age comes changes in functional ability and increasing vulnerability to chronic comorbid conditions. To foster well-being in older age and to decrease health system costs, it is imperative to establish comprehensive public health responses that focus on developing and maintaining intrinsic capacity and functional ability across the life course. The IFA's vision of a world of healthy older people who are both respected and protected underpins all that we say and do in the UN Decade of Healthy Aging. The decade's 4 action areas include combating ageism, age-friendly environments, integrated care, and long-term care, which are underpinned by a rights-based approach to healthy aging. 4 enablers to shift the status quo amongst the areas for action include voice and meaningful engagement, leadership and capacity building, and connecting stakeholders and strengthening data, research, and innovation. IFA continues to be a leader in the field by making and strengthening connections across disciplines and sectors towards a common policy agenda and towards a common development of new narratives about the impact of intrinsic and external factors on the functional ability of older people, including hearing health in later life. Moreover, to the rapidly aging global population, published studies in the Journal of American Medical Association, the NIA, The Lancet, and Johns Hopkins University, to name a few, have demonstrated the connection between dementia and hearing loss. These links between hearing loss and dementia build support for public health action to improve hearing care access. With the growing evidence, the IFA has committed to hearing in later life as a priority area with various advocacy-based initiatives. The initiative Increasing Cross-Sectoral Collaboration in Advocacy Efforts for Ear and Hearing Care Services aims to empower civil society organizations and stakeholders beyond the realm of hearing health to effectively comprehend, engage with, and advocate for ear and hearing care services. Through the comprehensive assessment of existing national aged care and dementia policies across 6 countries within the WHO regions, we aim to pinpoint existing gaps and opportunities that can be leveraged to support and encourage greater engagement and investment in this important issue. Our project focused on 3 key areas of interest, which were prevention, access, and equity. Under prevention, we looked at raising awareness and knowledge of having strong national policies for hearing health. For access, we looked at understanding and addressing structural and modifiable barriers. And for equity, we looked at timely and affordable ear and hearing care services for all and targeted advocacy efforts. Following a critical review of existing literature, environmental scans were compiled to highlight the degree to which hearing health has been addressed and integrated within both national aged plans and dementia strategies across the 6 identified countries. So the project had a focus on Japan, China, the United States of America, the United Kingdom, South Africa, and Saudi Arabia. Comprehensive scans were developed for each of the 6 countries and provided important insights into the current political prioritization of hearing and the barriers that exist towards supporting cross-sectoral advocacy efforts in this space. So we had some key themes that I want to talk with everybody about today. The first is in understanding the context of the countries studied, all 6 countries have rapidly aging populations with evidence of increasing prevalence of both hearing loss and dementia. This is important to build the argument as to why changes in policy and advocacy levels are so required right now. The second key finding we had was despite the current rate of aging and dementia and hearing loss, there remains a lack of inclusion of ear and hearing care strategies in national aged care plans and dementia care plans. So for example, 5 out of 13 national aged care plans that we studied across the countries of interest included mention of ear and hearing care services for older adults, and only 4 out of 9 national dementia care strategies across all countries of interest included mention of ear and hearing care for older adults. This highlights room for expanding the scope of policy for older adults as to include goals to addressing hearing health from multiple sources. Finally, another large theme was the lack of collaboration between civil society organizations focused on healthy aging, brain health and cognition, and sensory health. While each country had active organizations and civil engagement, there appeared to be little collaboration across those sectors. Moving on to the second phase of the project, IFA conducted semi-structured interviews with key national and international CSOs and field experts to gather data on advocacy initiatives and challenges to cross-sectoral collaboration. Identified stakeholders provided context on the challenges, including attitudinal, infrastructural, and access barriers to promoting ear and hearing care services, as well as seeking ear and hearing care. Some of the key findings from this part of the project included the many interviewees positioned hearing health in the broader framework of healthy aging and linked hearing health into the context of functional ability of an individual, and highlighted the cascading impacts of hearing health on family dynamics, society, healthcare systems, and economic stability. Others made mention of the difficulties in engaging in advocacy efforts and combating both the invisibility of the disability and the strength of ageist beliefs that normalize hearing loss. Interviewees also mentioned frustrations in the lack of collaboration between civil society, despite the strong shared interest between associations involved in hearing health, vision health, and brain health through their connection of wanting to maintain and improve function and creating age-friendly environments and cities. So there was a clear need for more engagement from civil society. The IFA is committed to working with partners to improve the interdisciplinary collaboration between hearing health and aging experts. IFA continues to deepen its engagement with existing partners like the World Hearing Forum by identifying shared objectives, including demonstrating the value of integrative hearing health into the broader framework of healthy aging. As trusted information sources, civil society can play a pivotal role not only in helping to shape and influence ear and hearing care policy, but also as champions for change throughout advocacy initiatives. As such, the upcoming IFA Global Conference in Cape Town, South Africa, will include hearing in later life as a central component of the conference program agenda. Here, the IFA will create an opportunity to bring together policy, aging, and hearing health specialists and civil society leaders to discuss hearing health in later life and gain consensus on key action areas to improve and advance ear and hearing care amongst older adults. So thank you so much for that brief introduction, and thank you again to the World Hearing Forum and Cochlear for helping out the IFA in supporting us. I'm now going to pass the floor to Dr. Sue Archbold. Dr. Sue Archbold, following a career of a teacher of the deaf, she managed the Nottingham CI program from its inception in 1989 until 2004. With her colleague Brian Lamb, she has published globally on the impact of deafness and hearing loss and of cochlear implants. She is now the coordinator of the CI International Community of Action, or KICA, and works with the WHO on the steering committee of the World Hearing Forum. Sue remains passionate about improving access to the best possible services for all who are deaf or who have hard of hearing. So I will now pass the floor to you, Sue. Thank you so much for joining us here today.
Thank you, Elizabeth. Thank you for that introduction, and thank you for that summary of this great project and this initiative, and thank you for all of you who've been working on it. So I'm going to kick off with starting to talk about ear and hearing care for older adults, about collaborative advocacy. And there's deliberately a question mark at the end of there. As Sarah Rubinelli said, advocacy requires organizational maturity, realism, clear planning, focused communication, social skills, and a genuine wish to improve the world. I'm sure that everybody here on this webinar wishes to improve the world, but let's see what happens. I'd like to introduce you first to Rosemary, my neighbour. Rosemary lost her hearing when she was in her 60s, had her implant when she was in her 70s. She's also got arthritis, she's registered blind, she has a husband with dementia, and she's taught me a lot. She says, when I went deaf, it was like living in a box. When I had my cochlear implant, I escaped from the box. Let's listen to what some others say, because measuring hearing loss in a clinic is only a part of the story. The impact of hearing loss is underestimated, and some have told us that losing your hearing, you'll lose your self-esteem, you lose your confidence, you don't want to go out. That's what deafness does to you. Somebody else said in a study we did, I had a problem with psychologically accepting that I was going deaf. Obviously, it's not cancer or heart disease, but it's a different sort of disability which leaves you feeling isolated, which can lead to depression. And somebody still in work said, I don't know if you're up to this job anymore, said the HR manager. You can't hear what people are saying. How can you do your job? I was possibly going so deaf, I wouldn't be able to work. So why is hearing loss a global issue? Elizabeth presented us with the facts and the figures that hearing loss is projected to rise to over 900 million people by 2050, according to the World Hearing Report. And if we look by age, you can see the ages along the bottom. And if you look at the marker that for 65 years, you can see a rapid increase in the incidence of hearing loss after the age of 65. So much so that 1 in 3 over 65 and over half over 85 will have a disabling hearing loss. And when we look at the growth of the older population that Elizabeth shared with us, those aged 65 and over are expected to increase by 800 million by 2050, with only 15% of those in high-income countries. If you go on Gapminder, you'll find some interesting facts and figures in there. And that growth in the older population then increases thus the numbers with hearing loss, of course. And the impact of hearing loss in adults is often unrecognized, as we'll be hearing further. It's associated with depression and social isolation, increased disease burdens, poor self-reported health, cognitive challenges, the greater use of medical and social services, for example, as the result of falls, greater rates of unemployment and underemployment, and hearing loss is a major cause of years lived with disability in the over 70s. But we have the technology today to change this, to help this. We have rapidly advancing hearing aids, auditory implants, listening devices, but we also have rapidly advancing communication aids with captioning, translations readily available, and communication technologies can help those of us with hearing loss to communicate more readily. We've got the evidence of the effectiveness of hearing technologies with both hearing aids and cochlear implants being shown to be effective and cost-effective. The European Hearing Instrument Manufacturers Association reports show increasing satisfaction and take-up rate of hearing aids. And that European Association doesn't only cover Europe. We're reporting that hearing aid users wish they'd had them earlier. With regard to cochlear implants, a survey of 1,000 adults with cochlear implants, we found 72% were very satisfied and 24% satisfied, the oldest being 92. And as WHO commented, cochlear implant is one of the most successful of all neural prostheses developed to date. So, is all well? Well, not exactly. Elizabeth showed us some of the results of their project, and whenever we think about hearing loss, managing hearing loss is not valued by society, as many have shown. Only 20% of those with hearing loss access the services they need. 8.9 years on average from needing a hearing aid to getting one. Globally, reported unmet need for hearing aids of 83%. And even in Europe, access to hearing aids is very varied, from 17% to 96%. With cochlear implants, only approximately 1 in 20 adults who meet the criteria access them. And still, a huge lack of awareness of cochlear implantation, with in Germany 69% of the population never having heard of them. So why should society be interested in improving ear and hearing care for older people? Well, there's the ethics, impact on the individual society, and we can do something about it, but also the financial impact on the society. With the World Report on Hearing reported that unaddressed hearing loss imposes a global cost of more than $980 billion annually. The cost of doing nothing is one we cannot afford. WHO reports a return on investment in ear and hearing care of $16 for every $1 spent. Not a bad investment. Spending money on ear and hearing care changes lives and saves society money, as we said in our Spend to Save campaign. But, always a but in life. It's not only the provision of hearing devices. Today's technology often isn't intuitive to use. The audiologist tells you, just use this app on your phone to control it. Just pair it with your TV. That might seem straightforward if you're very tech savvy, but not always. And if you're in a care home, if you've got visiting carers, if you've got sight and mobility problems, arthritis, not so easy. And it's not just about the technology. It's about everyday communication skills, addressing the accessibility issues, society's adjustments and attitudes, and the individual's adjustments to living with hearing loss, where peer groups can be important, as these two people found out. And the impact of hearing loss then in older people is wide-ranging, physically, mentally, socially, economically. And we do need cross-collaboratively advocacy action to address it, and also to include those who experience it and their families and friends. So collaborative advocacy is needed more than ever, and there's a lot starting to be encouraging. The World Hearing Forum at WHO started in December 2019. The World Hearing Forum dedicated to alliance, advocacy, and action. And if your organisation hasn't joined, please do so. We've referred to the World Report on Hearing. World Hearing Day on the 3rd of March has great examples of collaborative activities worldwide. And this year, it's about changing mindsets. Empower yourself. Have a look and join the action, because links to WHO and other resources will be available. Elizabeth will be providing those. So advocacy work about hearing loss and the impact is developing across the globe, is becoming more collaborative, although not enough, and sharing with the public, taking plans to government, and supported by the growing number of resources where the links will be available soon. And with Kicker, were founded after a global consultation on collaborative advocacy, with CI users, families, professionals, industry, and funders, and establishing a global advocacy network with 72 countries and 600 individuals and 100 organizations now. You can see our reach. What did they tell us in the survey about successful advocacy? A lot of work done by separate groups, but it was the coming together in one voice. Advocacy worked when there was real partnership, leadership, and a plan. They also told us about the barriers, of course. You might recognize some of these. Collaboration never works if you tell people what needs to be done. It needs to be from the ground up. Lack of time. If you've got a hearing loss, it can be challenging to advocate. You may mishear, misunderstand. Different motivation and priorities, competitiveness, and that's usually about power and money. Challenges of different cultures. And perhaps most of all, we don't listen to each other and we misunderstand the language we each use. For example, we need to be clear when we're trying to convince people and to advocate. This is an example. An audiologist was talking at a meeting about her research on bone-anchored hearing aids. We asked a funder of healthcare that was there listening, would you fund these devices? And the funder replied, I've no idea what she's talking about. She was talking in the language of an audiologist. He had no idea what she was talking about, and hence had no idea how he was going to make his decision. Well, this webinar is bringing together those with very diverse interests and priorities. And for collaborative advocacy to be successful, we need to understand each other's priorities and the language we use. We need to develop common goals and common messages, because politicians and funders love mixed messages. It's a good excuse not to do anything. Some suggestions from our survey to do this. We may not agree, but we have to find a common ground. People might have to cede some of their own power for it to work. Things don't happen overnight. Advocacy training is needed to do this. So to finish with, the World Report on Hearing recommends that we shift from services being designed around single health issues with everybody working in silos to services being organised around the comprehensive needs of individuals, families and communities. And I suggest we need to do that with our collaborative advocacy work, because hearing loss, as we've heard, and we'll be hearing much more, has real consequences and a huge unrecognised impact on individual and society. So we need to take action collaboratively with a clear message that investing in ear and hearing care not only changes lives, but actually saves society money. So I now look forward to hearing our other two speakers and to hearing perhaps what you have to say. Thank you, Elizabeth.
Thank you so much, Dr. Archbold, for such a lovely presentation. I will now be passing the floor to Dr. Kathy Pecora Fuller, who is a professor emerita in psychology at the University of Toronto and an adjunct professor in gerontology at Simon Fraser University in Canada. Over 3 decades, she has translated her research on auditory and cognitive aging to address the rehabilitative needs of older adults with age-related hearing and cognitive impairments, with a more recent focus on social engagement and healthy aging, including promoting brain health. Currently, she is past president of the International Collegium of Rehabilitative Audiologists, ICRA, and is the ICRA representative on the WHO World Hearing Forum. She represents the International Society of Audiology on the World Rehabilitation Alliance Working Group on Primary Care and serves. She has become chair of the Bowen Island Municipality Accessibility Advisory Committee in 2023. So welcome, Dr. Pecora Fuller. Thank you so much for being with us here today.
All right. Well, we've already covered a lot of ground, and I'm going to turn it around a little bit. So Sue has told you a lot about hearing, and many of the audiologists have probably heard some of that before. So that would have been new to the aging folks in the audience. But what I'm going to try to do is say, to continue Sue's message, that we have to shake hands, we have to walk together. And this World Hearing Forum that she discussed has a new working stream, the External Relations Working Stream. And the purpose of that working stream, which I am a member of, and which IFA has been a member of since the beginning, since the 2019 forum that we had in Geneva. We want to create this conversation that Sue has talked about between people who are hearing experts and people who are experts in other areas. And for the purposes today, that would be aging. So the audiologists also need to kind of broaden the way that they think about aging. So I'm going to try to turn it around a bit and make 4 simple points. So hearing health and healthy aging We just need to think about it. So from this day forward, we always think about them together. And you might have noticed on Elizabeth's slides that she mentioned the decade of healthy aging. And I think this has to be something that the audiologists learn about aging. And this may be that common point that we need to unite us, that the definition of healthy aging is about creating environments and opportunities to enable people to be and do what they value throughout their lives. So if we could make that happen, that would be a great common vision. And indeed, the vision for hearing that the WHO puts out is that we want a world in which no person experiences hearing loss due to preventable causes, and that those with hearing loss can achieve their full potential. So that's a pretty lofty goal, but let's just focus on that. You really need to read that World Report on Hearing that Sue mentioned, but you also need to read the World Report on Aging and Health and a lot of other brilliant documents that the WHO has put forward that we have a chance to connect to. Another one that is really, really important that already includes hearing is the ICOPE, the Integrated Care for Older People Plan. And Elizabeth mentioned age-friendly communities as one of the areas of the IFA. So we did write for the first time a background paper on hearing loss that was included in the World Report on Aging, which is summarized in this paper in the Gerontologist. We did get hearing in ICOPE. We should get more about hearing in age-friendly community approaches. So we have a stage ready for us to shake hands and walk forward together. Point number 2, ears are part of everyday life. So it's not just about hearing, it's not just about speech, it's about your everyday life and how do you actually use your auditory system? Because not much would happen if you couldn't communicate. Nothing in your everyday life will happen without communication. Sue mentioned the rise in the number of people with hearing loss. The hearing loss that was measured, it's often measured on, can you hear a little sound when you go to have your hearing test? What I just want to put a bit of a spotlight on is that most of the people in the world with hearing loss actually have mild hearing loss. So it may not be that they can't hear anything. They can hear something, they just can't hear very well. They can't hear easily. They can't hear efficiently. So it's this efficiency of living your everyday life, which is a huge story on the front of older adults. So they often don't have a lot of difficulty in quiet, simple situations, but they have actually beginning at the age of 40. So it doesn't show up on Sue's diagram because your ability to hear a small sound in a hearing test might not change, but your ability to hear noise begins to change in midlife, long before you arrive at a point where you might need a hearing aid. So this is really an important concept in gerontology, is that it's not just the abilities or disabilities of the person, it's how supportive or hostile is the environment. And the world is an acoustically hostile place. And if it is so hostile, it's not like we can't imagine the auditory equivalent of an elevator or a ramp. So even if you have a hearing aid, sometimes the world is just so adverse and communication is so difficult that you might withdraw. In your brain actually functions differently. This is a beautiful slide from Jonathan Peele, and the diagrams on the left are speech waves, and sometimes they're clear and sometimes they're distorted or they're noisy. So if a speech sound is clear, your brain uses auditory areas. The brain at the top has some blue areas. But if you have a hard time hearing because it's noisy, because you have some hearing loss, all of a sudden your brain can't really work unless it brings in the full power of other brain areas, the extra little red spots. So fundamentally, it's what can you hear in the worst conditions that may be important to your life? And we can measure the audiogram, we can measure how well people hear those little tones, but we also need to ask people how they're doing. This is from the Canadian Longitudinal Study on Aging. And we have that pure tone, the test of how you hear small sounds on the vertical, and how people reported they were doing in terms of their hearing, from excellent to poor. So even if we look in that green normal range, some people say they're not doing very well. And I suspect this is because they're older people and things have begun to change in their auditory brain, and they're trying to live in a situation which is difficult. So this actually is something that's pretty obvious to a person with hearing loss. And the people with hearing loss are going to every sector of the healthcare system, and they need to not have these experiences in healthcare. They need to not have these experiences in the world. So they say, when you're hard of hearing, you struggle to hear. When you struggle to hear, you get tired. When you get tired, you get frustrated. When you get frustrated, you get bored. When you get bored, you quit. So this is the cascade from the senses to the ability to think and concentrate, and your emotions to your ability to participate. So we really have to think about this as a cascade that begins in your ear and goes all the way through your life. Point number 3, this integrated person-centered care that Sue anticipated in her talk. This is a fabulous approach that the WHO has given us tools for. And basically, we do have vision and hearing loss, the senses, but we also have, if we're looking at the whole older person in this way that we want to support them in being able to do and be what they value, we're also going to look at cognition. We're also going to look at emotion. We're also going to look at mobility. We're also going to look at their physical health and things like, are they getting enough food? And putting these things, so we're putting Humpty Dumpty together again here: hearing, vision, balance, all the senses. They get all put together in your brain. Cognition is kind of the centerpiece of this. And then when we put it together well, you can do things like cross the street and have a conversation with your friend and remember the juicy story that they told you, so you can tell somebody else when you get home. So cognition is this machine that takes everything coming in and organizes everything going out. So there is no way that we can get from ears to life without going through cognition. In our audiology clinics, this is an example from Toronto, people don't just come in with hearing loss. They come in with that whole circle of conditions in the ICOPE model. So in this study that we did with hundreds of people, a third of them were over 90 years old. The average age in this clinic is 85. Most of them have some other condition other than hearing loss that affects their hearing care, and their hearing issues are going to affect all of their other care. So clinically, we have this imperative. If we go to settings like home care or long-term care, the green areas are where people have single impairments in vision, hearing, or cognition. Hearing very seldom occurs on its own. The blue is where we have 2 impairments together, and the red is when we have all 3: hearing, vision, and cognition. So, it's a package that we have to deal with in this holistic way. Fourth, okay, we're going to put this together in the clinic. We're going to do rehab. We're going to do accessibility in the community. So things may change when you get older, but health is really how do you adapt to those changes? And communication enables you to adapt. In that ICOPE approach, you see the red line is things which are declining, and the blue line is the functional improvement we can get with rehabilitation. And as Sue said, rehabilitation is about technology, but it's also about creating more hospitable environments and changing attitudes and behaviors. So audiologists can do that. Other rehab professionals can do that. We try to write about how to put sensory care into care for people with dementia in this World Alzheimer's Report in 2022. So we have in the diagram, the dark blue, the pieces of rehab: technology, environment, attitudes, behavior. But we also have the 3 levels. It's the individual level, It's the higher community levels as well. And this is also being done through the WHO, where the rehab professions are coming together to see how to support that integrated care. Audiology is at the table. Just for an example, in Canada, we have had a big project on interprofessional primary care, and this has resulted in a toolkit. So you'll get all these links and you can kind of get started and get some ideas about how to put it together. Sue mentioned, or maybe Elizabeth mentioned, I work on the accessibility committee in our little island of 4,000 people here on the west coast of Canada. And the design of this new community facility to make it accessible to include older people, we're working on good acoustical environment, good technologies, and training the staff and the user so they know what to do. Not that, yeah, it's an app, so just go and do it. We actually have to get in there and make it happen. So that's my island, and I'm going to pass it over to the next speaker.
Thank you so much, Dr. Pecora Fuller. That was a wonderful presentation. And now I'm going to pass the floor to Dr. Joshua Chodosh, who is a clinical geriatrician and professor of medicine and population health at NYU Langone Health and NYU Grossman School of Medicine. He is director of the NYU Division of Geriatric Medicine and Palliative Care and the Integral Endowed Michael L. Freeman. He's a professor of geriatric research at NYU Grossman School of Medicine. He's also the deputy director for clinical translation in the recently launched NYU Optimal Aging Institute, and he leads the outreach recruitment and engagement core of the NYU Alzheimer's Disease and Research Center. So thank you so much for joining us here today, and the floor is now all yours.
Thank you very much, Elizabeth. These are two very hard acts to follow. I think you heard really terrific presentations from both Sue and Kathy, and I will try to keep it going here. You heard a lot about society, I think, in the world and some very important international efforts. And I'm going to focus a little bit in a little bit more granular level with some personal experience and hopefully inspire you that at least as a physician, some of us who are not in the in the hearing world as otolaryngologists, for example, that some of us actually, particularly in geriatrics, do really care about this problem. It's really a very important problem. And as Kathy highlighted, we never see someone who comes in with less than three significant problems, at least in my world. And would they come in with just hearing loss? We might see a very different set of strategies. And I think this is part of the problem because it is often a silent disability and one that people do not notice and is really covered over by both individuals who are affected by this problem as well as the clinicians who care for them. So what I hope to do is both give you a physician's perspective, but really focus on this notion. You heard a lot about cognition and the brain, and I think the brain really is at the center of this. But communication is really what's most essential for us, certainly in healthcare, but I think for us in life. And you heard that from Kathy. And in the absence of real conversation, certainly as a clinician, we fail to detect um, any increased effort in listening and understanding. And that's really what we're faced with when our patients come in who are faced with these problems. And moreover, when we see people with communication challenges, whether it's in the clinic or whether it's in life, unfortunately, I think we often conflate this with cognitive challenges. And yes, if you can't hear well and you can't communicate, cognition is affected. But in no way should that be some summative conclusion about the state of one's brain. And when cognitive performance suffers, it is a bit of a vicious cycle in that listening is certainly more effortful. So these things certainly do work together. So why does this happen? How does this even happen? And I think you've already heard that even at the age of 40, you can do pretty well in a quiet environment. But maybe when you start, going out and socializing, and you're particularly if you're in a noisy restaurant, I think is the most common example. It's really hard to carry on a conversation, and yet you would not be someone who, if you went to see the audiologist, necessarily be detected as having hearing loss. You would hear all those sounds in the hearing booth. But for us, when we truly develop age-related hearing loss that's measurable, even in quiet office environments, fewer words are recognized. Discussion is often misunderstood, or even incomprehensible, and folks who have this effect may, in fact, appear to be impaired to others. And you heard a little bit about this challenge in effortful versus effortless hearing, but really want you to think about this from the standpoint of cognitive bandwidth. I, in fact, might be able to hear every word you're saying, perhaps even in a noisy environment, if I work hard enough at doing that. But in fact, I'm using most of my cognitive energies, most of my what we would call cognitive bandwidth to succeed in doing this. And with that, I'm far less able to listen, encode the content, and derive anything that's meaningful from that conversation. This is really analogous to sitting in a lecture hall and being the note taker and walking out and running into someone who wasn't there and said, "What did the professor say?" And you say, "I don't know. I have to look at my notes." "What do you mean? You weren't there?" "No, I was there. I listened to every word. I got them all down." But you never had the opportunity to really bring that information in and derive meaning so that then you could work with it and describe that to others. And encoding content is that first step to both our immediate memory as well as our long-term recall. And you heard this concept about effort and fatigue, and we often use the term checking out. How many times have you seen someone who has significant hearing loss and looks like they just have a vacant stare, and maybe you speak to them and they just smile and say yes, but they're really not hearing and they're not engaged because it's too hard. And in fact, it's often too embarrassing. So better just to be present, but not really be interacting. And I want to emphasize here that decreased cognitive performance, even though we know that there is this relationship, does not equal dementia. I cannot say that strongly enough. There are many people with age-related hearing loss or who are deaf who have had hearing loss for their entire lives and do not have brain neurodegenerative changes. So let's unpack cognitive impairment a little bit. And really what we're talking about here is dementia. It can be a hard conversation to have because we're afraid of this. We're afraid of getting this for ourselves. Why? Because this is something that affects our personal agency. It affects our personhood. And this fear in part is really motivated by misunderstanding. This is really, it's just a word. And it's a catch-all that has a very specific set of criteria, however. Um, but those criteria also describe many possible root causes. It really is an umbrella term for many different conditions. And here you can see the criteria that are described by the DSM-5. And I put these here because this actually gives us great facility in being able to identify what in fact is actually a dementia condition without having to do necessarily detailed, elaborate, or sometimes hard to access tests. And really, that is the loss of cognitive abilities over time that affect our ability to remain independent in our day-to-day activities and is not due to some other condition. That is really it in a nutshell. And this is what the DSM-5 looks like. I put this here because we actually apply this in our everyday work when we're trying to determine whether or not somebody is at risk for this condition and meets these criteria. So cognitive screening, one of the things that we've heard a lot, and we've heard a lot from my audiology friends in the audiologist community, is that there's a lot of concern now that audiologists should be doing cognitive screening. And I would argue that it's really not in the wheelhouse of an audiologist, just like it's not in the wheelhouse of somebody who's in a community center where older adults are coming in for their day-to-day activities. And it's not there only because there often is a considerable lack of connection to the healthcare system. And so that's problematic for someone who might be screened and then told that they failed the screening test and now what they do. That in fact could be quite harmful. But screening is really screening is really there to determine whether or not this is something that should be evaluated further. It's not diagnostic, and I think this is where people start to get worried and anxious that we need to be doing this, and this is an activity. Certainly, we should all be detecting cognitive problems in our everyday lives, whether it's our family or friends, or it's people that we happen to encounter in a chance moment, because we should then be in the moment of trying to be helpful. And anyone who raises concern about their thinking or memory should in fact have an evaluation. And so those cognitive tests that even I do in my clinic really are something that would indicate whether or not something more should be done. And unless this is embedded in what I would argue is at least a strong informal relationship, we really put people at a psychological cliff. We don't have that. So I really caution people when they're thinking about hearing loss and dementia as not being now armed that we have to start screening all of our patients who walked into an audiologist clinic. And certainly what's most important, and I say this to my learners in our healthcare environment, if I've got a person in front of me who's concerned about their hearing and they have concerned about their cognition and they have hearing loss, and I have not corrected that hearing loss during that visit, then my cognitive assessment is going to be far less reliable. So what is it about this relationship between hearing and cognitive function? You've heard a bit, I think, quite eloquently from Kathy about this relationship of the psychosocial consequences, and Sue talked about this as well. And certainly this is super important because if we improve hearing, we do in fact improve health, but we need healthcare strategies to do this. And this does not mean that there is no relationship on a biological level between hearing loss and brain function. We know that there is, and we know that volume loss specific to auditory related brain regions do occur in the setting of hearing loss, but whether or not this is neurodegenerative or not really remains a continued question, a really important question for all of us, and for which I think some really important work is ongoing right now. I like to equate this with our muscles, for example. If you don't use your muscles atrophy, they become smaller. And so the question becomes then, if you restore hearing and you do have some loss, you have some restoration of some areas of your brain that you weren't using before, do in fact you see some restoration of whatever someone might describe as atrophy? We actually don't know the answer to that question. And you've heard this trial. The ACHIEVE trial was a randomized trial that really tried to address this relationship between hearing loss and cognition. And half the population that was randomized got hearing aids over a 3-year period, and half didn't. And the overall group actually showed no change in cognition. Maybe the time interval was too short. Maybe there were other reasons that there wasn't a change. But in what was called the ERIC cohort, and this was a study that included an existing cohort as well as other people who were then recruited into this study, the ERIC cohort really represents a population of much greater diversity. And with that greater diversity, much greater challenges in what we would call social determinants of health. And in that group, there was a statistically significant change in score. But what I would suggest with that is that the actual intervention was quite intensive, and that intensive intervention was oral rehab. So this is something that clearly happened in the intervention group for that subgroup in ACHIEVE. And so again, think about what you all do in your day-to-day lives, whether you're audiologists or other healthcare providers, or you're supporting those of us who do this work. Clearly, our relationship with people in need makes a big difference. And so how much of this relationship was in fact important in improving or making those individuals' cognitive changes less significant than those who didn't get the benefit of that relationship? In this case, it was the relationship with an audiologist. So what about hearing amplification and care? And in this instance, to just briefly describe what we did in an emergency department. We talked about, hearing, listening, but hearing but not encoding. And we really looked at if we could identify people who self-described as having hearing loss, whether or not when we provided them with a hearing amplifier, how would their care change? And so we did this in a randomized pilot study. We're now in a much bigger study. Let's see if I lost my mouse here. And we did a number of measures here to assess what was the impact of this. Most importantly, I want to highlight their understanding of their discharge information. And that is bouncing around. And we also looked at what happened to them, whether they came back to the emergency department, which was very frequent. And so we were able to randomize over 130 people. The thing that was most astounding to me was how quickly people signed up for this trial and wanted to have their hearings, wanted to answer hearing screening questions during an emergency department visit. That tells me that there is considerable need out there. And what you can see here is when you look at the group on the top bars for each group, that was the intervention group, we see across the board improvements in noting things like clear voices, able to hear sounds they wanted to hear, noises that didn't cause problem for them, understanding what they said, and being able to understand without making an effort. And these changes weren't big changes, but I think the ones that I've highlighted here, I think are perhaps the most important, especially able to understand without effort. That was that cognitive bandwidth thing I was talking about earlier. But here's where it became really important, and I want to highlight this. This may be, in fact, the most important thing that I want to say. You saw almost a threefold difference, at least a 2.5-fold difference between patients who got pocket talkers or hearing amplifiers during their visit and those who didn't, being able to say that they were told what was wrong with them when they left the emergency department. That's pretty astounding. That means that that those who didn't get any hearing assistance, only a third left with an idea of what was wrong with them. How do you even begin to take care of yourself and follow any kinds of instructions after an emergency department visit? I actually don't know how. So we also saw that their revisit rate, which was what we were most interested in fact, was a threefold difference. Although this was a pilot study, and so we don't know whether that will hold up in a larger trial. So what is the audiologist's role? And I have this here because I suspect many of you on this webinar are in fact audiologists. It certainly is using it's really not different than anyone else. It's using what I would argue is a low-tech approach to detection, and that's a conversation. And that's understanding whether in fact there is concern, there is a problem, and something needs to be done. And why would you want to do that? Because you may be in the path of an impending crisis, and therefore might be a person who could in fact prevent that from occurring. And so having this conversation that's reassuring and normalizing, I do want to highlight, I do lead a center of excellence for our CDC here in the US, and this is on early detection, and encourage you to go to bolddementiadetection.org to see a number of tools and instruments that should be very helpful to you if you're interested in working in this space. And also, you should be in the space of being able to explain, as I do for my patients, how hearing loss exacerbates your cognitive abilities, and therefore doing something about that, not just getting hearing aids or cochlear implants, but also understanding what are your best listening environments can be enormously helpful. So where do we go from here? I think we've heard a lot of really tremendous information here that's very useful, but we have lots of these, and then maybe we go home and say, well, what's really going to happen? I think any change that's going to happen has to be incremental. We can't change the world today, but we can do small and important things. And I would argue that not only in the United States, but around the country, in fact, this is happening. Emergency departments are becoming more gerry-friendly. Certainly the industry world has picked up on this and is promoting hearing aids writ large. And I think you heard from Kathy's talk, even the built environment as a really important exemplar of how we create spaces that are going to be more conducive to better health and better hearing. And I would challenge you to ask, if you want to improve hearing healthcare, what are you going to do right now? What is going to be your role? How are you going to incorporate any new strategies? And what does reasonable change look like for you? So thank you very much.
Thank you so much, Dr. Tradash. That was an amazing presentation, and very thankful for your time and expertise with us here today. We have a few moments left here for some audience questions. So I'm just going to go into the chat and see if there's any questions that we can pose to our expert panel here. And please do feel free to add your questions in the chat there as well. I see a question here that is from Shmuel that says, question for Sue. What needs to be a role of governments and authorities in effective development and implementation of advanced hearing technologies? So we'll start off with Sue, and if anyone else has any thoughts as well, we welcome that as well.
Thanks. A great question. And so I think that could be a day's seminar. Before I answer it, though, while I have the floor, I'm going to follow up on Josh's presentation. As somebody that I worked with, the chairman of the board, he always said to me when I was going on in a wide-ranging way, as I do, he used to say, "Yes, Sue, but what are you going to do on Monday?" So I would just like to present to the 134 people who are still attending, what are you going to do on Monday? And as Josh said, it can be tiny, tiny steps, but gathered together, they will make a difference. So back to the question. Well, it's about money, it's about funding. We're not very good about talking the talk, about advocating. I gave that demonstration about a funder not being very impressed about what he heard. He certainly wasn't going to be funding bone-anchored hearing aids because he hadn't a clue what they did. And I've spoken with lots of funders and commissioners of healthcare over my time. And what they have said to me is, make it easy for us. One said, I'm funding wheelchairs in the morning and I'm funding cochlear implants in the afternoon. Will you just make it easy for me to decide where to put my money? I'm not a bad person, really. I just need your help to show me where to go. And of course, the other obvious answer to the question, though, is that ear and hearing care just needs to be part, as WHO are advocating for, part of national health plans in every member state of WHO. And we all need to be working collaboratively towards that. But I'm sorry, Shmuel, if there was an easy answer to that, I'd have cracked it by now.
I would make one. Can I add one comment to that? So just one really simple thing, and I believe this is probably international. When you go for a medical visit, I bet you get your blood pressure checked. It's very unusual not to have your blood pressure checked. In fact, some people might consider that negligence. Why? Because hypertension is so important and because it's eminently treatable. Well, so is hearing. And so why shouldn't hearing become a vital sign? Why shouldn't, if over a certain age, maybe it's 40 years old, as we heard today, but at least if it's over 60 or 70 years old, why shouldn't that be a vital sign question? Even a simple question. And I understand that a single item question is not going to capture this. We've studied this, but it certainly is a start. It is certainly something that now changes people's sensibilities about themselves, changes practitioners' sensibilities about people, and may in fact start a new set of awarenesses and increase the level of its importance. That's just one small, simple change.
Can I just add to that? I know you're going to say we're up for time. When you go in England, we call it your GP surgery, your general practitioner. While you're sitting waiting, there's leaflets about everything, but rarely are there leaflets about hearing loss. So we made some leaflets about hearing loss, which were funny with cartoons in and so on, to put in there so that while people are there, instead of reading about obesity or getting a meningitis vaccine and so on, they could read about hearing loss and maybe spur some people to go and actually taking some action.
Thank you.
I think if I just to kind of go back to the beginning, the way forward is to work together. So there's already, we don't want to start talking about hearing. We want to join forces with everybody else who is working on the health and well-being of older people. So I think, these tools like ICOPE, the tools like the World Report on Hearing as an accompanying document about screening. So what Josh just said about why don't we screen, it's all in there. So we have all these pieces, but we just need to share them and we need to work together. So I think, if we work together, then the path forward is going to be easier.
Thank you so much. And I think that is a lovely note for us to end on and a future direction for us to go. So I want to take the time to thank you all for your expertise in contributing to our webinar here today. And I encourage anybody who has any additional questions to reach out to myself. And I will also be sending out some post-session resources, including the links that our speakers have provided in the coming days, as well as a recording of this webinar for your use and dissemination. So thank you all again so much for your support and have a wonderful rest of your day.